Thank you for the opportunity for me to give this talk on the 6 P's of healthcare, future of price transparency, and reference pricing and surprise billing. So when I look at the healthcare system, I always divide this up in the 6 P's of healthcare, which are the providers, the patients, the purchasers, the payers, the policy, and the politics. Now, when I look at healthcare from my own minds, I always look at it in healthcare and make the analogy of who owns the car. And what I mean by this is that when my son was growing up, we ended up getting him a car. Now, we certainly didn't get him the nice Corvette that's seen in the top left-hand corner, but we did get him a car. And the issue was who owned that car. Now, he drove it every day, so he felt he owned the car. I'm the one that had to pay the monthly payments, so I felt I owned the car. But eventually we had a lease, and then the car had to be given back to the Lexus dealership, so they felt that they owned the car. And I think there's a similar analogy regarding who owns healthcare. So in healthcare, we have to be patient-centric. So the patients feel that they own the healthcare. However, the hospital systems feel that they own the healthcare. They're the ones that have the buildings, they have the capital, they have to take the risk, they have to turn the lights on, they have to pay the employees, they have to deal with unions, so on and so forth. So they feel that the healthcare system revolves around them. We as providers feel that we own healthcare. Why? Because we're the one that takes the risk. We're the ones that provide the patient care. If there are no providers, there would be no healthcare. So we feel we own healthcare. But from a purchaser standpoint, they're the ones that actually purchase the care. So they're the ones that pay us as providers. They're the ones that pay the hospital systems. And they're the ones that purchase services so their employees can get the healthcare. So organizations such as the Blue Cross Blue Shield and the GMs of the world and the Fortune 500s, they make a convincing argument why they feel they should own healthcare. Now, one of the key principles that is driving purchaser-directed healthcare and some of the tactics that we'll be talking about is the fact that the median US income in 2019 was $65,712. The total employer and family premium was $20,000. And the employee premium contribution was almost 9%. So essentially 9% of this, almost 10%, is going to be $55,000 after the premiums were paid for by the employee, which means they only have about $55,000 to take care of a family of 4. A lot of the healthcare expenditures that employees end up having are post-tax expenditures, and these include deductibles, co-pays, co-insurance, and balance billing. So just from a definitional standpoint, a deductible is defined as a specified amount of money that the insured must pay before an insurance company will pay a claim. A copay is a predetermined payment made by the patient for a healthcare service. A coinsurance is a percentage of a medical charge paid by the patient with the rest paid by your health insurance plan, usually after the deductible has been met. And then the balance billing is when a provider sends a bill to the patient with the amount the insurance company doesn't pay. So therefore, in a way, the provider feels that they're being shortchanged by the insurance company. Now, all of these expenditures are post-tax expenditures, and again, not factored into that 8% of the employee premium. So part of the challenge as to why employers are now getting more involved is because the employees are faced with some very challenging issues in our current day environment, and they end up complaining to their companies. And the companies are looking for a way to reasonably reduce costs. And one of those ways is the concept of the reference pricing. Now, this was a slide actually taken from one of the consultants' presentations. And so the description from the consultants and the employer's presentation is that a reference pricing is a fixed reimbursement for quote unquote a shoppable service based on market costs with the goal of driving lower cost options. And in this case, they specifically looked at MRI and CT and also elective surgeries. So if you will, our services are now being targeted for possibly reference pricing. Now, reference pricing is not completely outside of the radiology literature. This was a paper that was published in 2013 in the JACR, where they actually looked at the concept for reference pricing when it comes to imaging. And the assumptions were that the imaging had to be a commodity procedure, substantial price variation, standardized quality, and interchangeability. And these were the assumptions that had to be met in order for reference pricing to be successful. Now, from an employer standpoint, what they're trying to figure out is how much does it really cost for us to provide our services? And this was another slide that was presented to me by one of the consultants. And when they looked at this, they looked in blue here of the average CT scan charge. And we can see the charges all over the place. Again, that's not payment, that's the charge from the charge master. And then they looked at the average CT scan cost. So from their perspective, and again, when they're dealing with non-physicians, they look at this and say, my gosh, some of these places almost have a $2,000 to $3,000 margin. Again, this is charge, not the actual payment. But the challenge is, and it raises a good point, is what is the actual cost of us performing a CT scan? Well, there hasn't been that much in our literature specifically looking at the cost of a CT scan. This is a very nice paper that was written in 2017, and it looks at the direct costs to deliver a CT scan. And this paper looked at it from an outpatient setting, the emergency department, and an inpatient setting. And they identified that the two largest cost drivers were personnel and interpretation. Now, this paper did not specifically address the actual cost, the dollar cost. It looked at it in percentages. And I remember I talked to one of the authors, and they specifically said they did not look at the individual cost. So even in our own literature written by very experienced people, we still have a hard time drilling down the actual cost. And so as a result, when our purchasers look at our services, they're trying to figure out what is a reasonable cost for this service that they're purchasing. So there are various ways for employers to look at this. They can look at things such as Medicare, Blue Cross Blue Shield payments, and other benchmarks such as Healthcare Blue Book and Fair Consumer Health. And when they do this, they can see there's a wide variation of reasonable costs for, in this case, CPT code 70553. This is the brain with and without contrast. And it's not just limited to neuroradiology. When we look at areas such as the knee, we can see another wide variation of costs between Medicare and Healthcare Blue Book. So when we look locally, a lot of the groups right now are now doing direct B2C marketing. So when an employer looks at this, they can go to this one website and find out that an MRI with contrast is $750, whereas with contrast is $850. They can then go to another provider, again, in our same market, saying that they can get an MRI scan for $299. So the challenge that we have is what exactly is our quality? How does a healthcare provider or a purchaser determine quality? Now, you can make the argument that even those two areas that I showed before, if you have the same equipment and the same fellowship trained radiologist with the same fellowship training at the same institution, well, you know, that quality, it's probably pretty similar. But from a global standpoint, we understand that there is a difference in quality based on equipment, such as technology, age, and certification, and also the training of the radiologist. Are they a multi-specialty radiologist or are they a fellowship-trained radiologist? And I know specifically if I have to have a procedure like this, I would want my radiologist to be the best trained person as possible. And this was a nice study done a few years ago, identifying that when a subspecialty trained radiologist went back and re-reviewed images that were performed at outside institutions, there was a change in interpretation in approximately 41% of cases. So we know inherently as providers what a high quality is when it comes to subspecialty training. But the challenge is, from an organizational standpoint, we as an organization, as radiology, have a hard time defining quality. And as a result, in this classic 4 quadrant, where our purchasers want to be is they want to be in the lower right quadrant. They want higher quality with lower cost. Where they don't want to be is lower quality and higher cost. And again, the challenge that we have as a specialty is that we have a hard time coming to a consensus definition of what quality is. And as a result, sometimes quality is being defined for us. So the whole concept of quality is now being focused from the purchaser standpoint, because as I mentioned before, they want to be on the lower right quadrant. So Walmart in 2012 started the Centers of Excellence program, where they looked at 15 destination sites and they looked at specialized surgical care, specifically cancer, organ transplant, spine, knee, cardiac, and bariatric. And they specifically launched active purchaser steerage. And when they looked at this, they identified that if they could send their patients with these very complex procedures to certain centers, there was an approximately $5,000 to $12,000 savings per patient. Now, the initial reaction to this, well, where are they sending these patients to? Are they low-cost providers? How is the quality? But when you actually look at the participating centers, these are very good centers. The Cleveland Clinic, Emory, Geisinger, Hopkins, Mayo Clinic, so on and so forth. So they are getting more and more focus in steerage to send patients to areas where they feel that they're getting higher quality. Now, this was an interesting paper that was published a few years ago in our literature, in which they had one patient, a 63-year-old woman, that went to 10 different MRI centers over a 3-week period. And when they looked at this, what they found out, that study authors found there was a marked variability in the quality and accuracy of MRI evaluations across these imaging centers. And when you look specifically, nearly 1/3 of the findings appeared in only one report. Only one finding appeared in 9 out of 10 reports, and none of the 49 distinct findings were unanimous. Now, we understand that when we as radiologists look at especially something like spine MR, there's a certain variation to this. Now, what was unclear from this study was who needed surgery and who did not need surgery. But when the employers looked at this, the purchaser looked at this, and they found this large variation in interpretation. They are now saying that this indicates that there's a high misdiagnosis rate when it comes to imaging, and the potentially high misdiagnosis rate that can lead to inappropriate surgeries. And this was one of the tailwinds that caused this recent collaboration between Walmart and Covera. The importance of imaging is well recognized by our purchasers. This quote is from Lisa Woods, who's the senior Walmart US Director of Benefits and Designs. And she says the quality MRI can improve the accuracy in diagnosis and care journey, helping to create the correct treatment plan with the best opportunity for recovery. The challenge is that they were concerned that too many employees are having misdiagnosed health conditions, leading to unnecessary surgery and wasted health spending. And up to 50% of the company's workers who went to the Mayo Clinic and other specialized hospital for back surgery did not require surgery. And therefore, in May 15, 2019, Walmart and Covera started this collaboration, which was a multi-year effort to reduce unnecessary treatment based on misdiagnosed imaging exams. And they recommend now employees covered under their plan, this was of 2019, we use one of 800 imaging centers classified as providing high quality care. This was expected to increase to 1,500 by the end of the year. I'm not really sure what happened with COVID that year. And what they claim was that price was not a factor in choosing Center of Excellence. So this was in May 15, 2019. And then on September 1st of 2020, Covera landed its first partnership with an insurer, which is Premier Blue Cross in Washington. So this whole concept was trying to gain traction. And now there is one of the payers that is now focused on active steerage. Another important trend that's happening is the purchaser-directed healthcare. Now, this was Haven, which is a collaboration between Amazon, JP Morgan, and Berkshire Hathaway. And I think we'd all heard of this. In 2018, Atul Gawande became the CEO. The intent was to increase value and lower costs for company employees by providing easier access to primary care, more affordable prescription drugs, and transparent insurance benefits. Now, combined, these three large organizations had 1.2 million employees, but they found out that healthcare was very complex, much more than they could tackle. And this, even though there were 1.2 million employees, this was insufficient manpower, and this was disbanded in February of 2021. Now, Amazon started Amazon Care in 2019 for Washington state employees, where they provided free telehealth, fee for nurse in-home visits and vaccines, and expanding virtual care to all of their employees. And this was in 2019. And in March 2021, ironically, about 1 month after Haven was disbanded, Amazon announced the expansion of Amazon Care to employees in all of their 50 states. And again, we know how big Amazon is and the power they have. So now they are actively in the healthcare provider space. And the last thing that we'll talk about is surprise billing. Now, when we talked about copays, coinsurance, and balance billing, these were unexpected bills and not surprise billing. So there is a subtle difference. Surprise billing are unanticipated bills from clinicians who provide services that are not in network in the patient's insurance plan. So therefore, their bills are going to be much higher than anticipated. Now, this has always been a big topic. In 2021, the surprise billing legislation was passed at the federal level. And to summarize the surprise billing was barred for emergency care, specifically for out-of-network providers. It was barred for air ambulance, and patients who did receive care in out-of-network facilities were asked to pay in-network cost. For non-emergency cases, providers may bill for out-of-network services delivered at an in-network facility if it's disclosed to the patient within 72 hours in advance. So you have to have that 72-hour trigger. Now, for things that fall through the crack, there is a reconciliation process. So there's a 30-day period during which the payer and the out-of-network provider try to attempt to reconcile a payment. And this is a baseball-style arbitration, where the payer says one thing and the provider says another amount, and basically it's up to the arbitrator to determine which one. So it's not a true, if you will, negotiation. It is a baseball-style type arbitration. So you have to be very clear as to which price you think is reasonable. So in summary, what we talked about is a lot of the strategies now and the importance of purchaser-directed healthcare, and the take-home principles that I want to leave you with that's really fueling this. We have to ask, why is this happening? Is because remember that the median income for a family of four is $65,712. Immediately, about $10,000 of this is going to healthcare premiums. The minimum wage is approximately $7.25 per hour. Purchaser-directed healthcare, some of the strategies because of this, because a lot of the employees now are going straight to their benefits managers, is that they're looking at strategies such as reference pricing, employee steerage, and billing transparency. And we also talked about surprise billing. Thank you very much for your attention.